Welcome. In this clip, we're going to be continuing a discussion that has been developing in this medical ethics course, and that's the question of how inequality and discrimination emerge sometimes in the practice of medicine. And in this video, we're going to be looking specifically at sex-based inequalities in medicine. Problems that are faced by female patients in particular. So here's the plan. I'll tell a story about a drug called thalidomide, which then leads into certain policies that were developed that involve excluding women from pharmacological research. And we'll see some of the ethically problematic consequences that have emerged from those policies. And then in the second half of the video, we're going to shift gears to a particular case involving consent for gynecological examinations, especially as these examinations are performed in teaching hospitals. So we'll look at some arguments for and against certain laws and policies within gynecologic care. Now, before we get to those things, I just want to make a short preamble about sex and gender. So I will be talking about sex-based inequalities within healthcare. The issues that I'm going to be talking about are issues that emerge for people with certain hormonal characteristics, and also issues that emerge for people with certain kinds of anatomy, i.e. a person with a vagina with a uterus such that this person will be receiving gynecologic care. So in some ways we can think of these issues, and we would typically think of these issues as problems that women face in healthcare. Now, I think that we need to talk about this because the issue of transgender people is a contentious and hotly debated issue within contemporary society. The approach that I want to take wants to be inclusive towards transgender people. So I just want to talk a little bit about my terminology and the rationale for how I'm going to use certain terminology throughout this video. So commonly, contemporary terminology will treat sex as a biological concept. So when we say that the sex of a particular individual is female, what I understand that terminology to mean is that it's referring to having a certain hormonal profile, or it's a matter of having XX chromosomes, and it's also associated with particular phenotypic traits. So for instance, a phenotype is just the way your body presents itself and the way it behaves. So we can think of a phenotypic trait of a female as involving things like having ovaries and a uterus, or menstruating, or being able to become pregnant and give birth. Whereas sex is a biological concept, we can also talk about the concept of gender. Now, typically in contemporary discourse, gender is treated as a social and psychological aspect of somebody's sex and gender identity. So we would think of a person's being a woman, rather than just being a female organism, but being a woman, as identifying as a woman and also presenting oneself in social contexts as a woman. Also things like using she and her pronouns. Now, some people get the picture that, oh, well, a person's sex then is straightforward, it's simple, it's cut and dry. Either you're female or you're not, either you're male or you're not, whereas gender as a psychological thing is on a spectrum. I think that we should pause and notice that both gender and biology are complicated. So we might realize that there are people in this world with XXY chromosomes, And in this way, at a genetic level, we can see them as having both female traits, that is, having two X chromosomes, and also male traits, having a Y chromosome. And phenotypically, a person with XXY chromosomes will not fall directly into one or the other box when it comes to the sex binary. Another really clear example of how biology is complicated and not a perfect and simple binary is androgen insensitivity syndrome. Now, when somebody is born with androgen insensitivity syndrome, they will typically be assigned female at birth, because a person with androgen insensitivity syndrome will be born with a vulva, a vagina, and no external testicles or a penis. But the thing about a person with androgen insensitivity syndrome is that they have XY chromosomes, like a male, rather than XX chromosomes, like a female. So what's going on with a person with androgen insensitivity syndrome is their cells and their hormonal makeup is not responsive to certain kinds of hormones, androgens. And these androgens are the cause of the development of a penis and external testicles during fetal development, during embryonic development. Now, in this case, we will find that a person with androgen insensitivity syndrome can be perfectly healthy, although they will not have all the traits of a typical phenotypic and genetic female. They will also not have all the same phenotypic traits of a typical genetic male. In fact, a person with androgen insensitivity syndrome will not have a uterus, and in fact, they don't have ovaries. They actually have internal rather than external testicles. But the reason why I'm talking about androgen insensitivity syndrome is that we need to realize that sex is very complicated, just as gender is. And some of the issues that I'll be talking about in this context, they'll be most easily applied to cisgender women, that is, women who are assigned female at birth, who have all the phenotypic traits of females, and who identify as women. Although some of the issues may be faced by certain intersex people. And we should also acknowledge that there are particular and also important problems faced by transgender and intersex people within healthcare. So for my terminology for this discussion, what I'm going to try to do is when I'm referring to a patient who has a vagina, a uterus, who is with XX chromosomes, I'm going to use the term female patients. And that's to talk about having certain biological sex characteristics, because that's what the issues I'm going to talk about are really going to be focusing on. But I don't want to claim that even though these are issues typically faced by people who identify as women, some of these problems will be faced by people who do not identify as women, and some people who identify as women won't deal with these specific problems. So with all that said, let's think about some particular cases, and I just want to talk about one important moment in the history of sex, gender, and pharma research, and this is a drug called thalidomide. Now, thalidomide was introduced in 1956 as a sedative, and it was eventually found that a secondary use of this drug is that it could also be used to manage nausea. So in this process, they began to give thalidomide to pregnant women to deal with morning sickness. Now, when this began to happen, many children of mothers taking thalidomide were born with birth defects. So people whose mothers took thalidomide during pregnancy, often their limbs will be missing or malformed. And it took about 5 years for this problem to be identified and to have thalidomide removed from the market. Now, as a result of thalidomide and a number of other similarly concerning adverse reactions for pregnant people, the FDR barred female patients of reproductive age from participating in phase 1 and phase 2 drug trials. And this ban on including women in drug trials lasted until 1993. So it lasted for about 15 years. And it wasn't until 2016 that the National Institute for Health mandated that disaggregated data, that is, data that includes separate results for both female and male research participants, that wasn't required until 2016. So what we have is a long history of exclusion of female patients from drug trials, as well as we also have a lack of data on female patients within drug trials. And what happened by excluding women from pharma research? And the argument was, we want to protect these women and their babies from coming to harm, right? But what we find from certain data is that women actually do come to harm by being excluded from high-quality research. So in our reading by Nowogrodzki called Inequality in Medicine, she points out that female patients will often suffer more drug-related adverse events than men. So over a stretch of time, there were 2 million adverse events for women compared to 1.4 million for men. And many drugs that were put on the market and then removed for being problematic or unsafe were removed because of adverse effects that were only occurring with women. And this is partly because, due to these old FDA bans and policies for how drug trials are set up, many female patients who participate in drug trials are only allowed to begin to participate in these drug trials at stage 3. Let's fill in what these stages mean. At stage 1, it's a matter of just making sure that a drug is safe, that it won't kill a patient, that it won't bring them a great deal of illness. And they also begin to work out dosage levels. So what dosage levels are safe, and also what dosage levels are effective. And then at stage 2, they begin to work out whether the drug has any efficacy. That is, like whether the drug is doing any better than a placebo or the standard treatment. And they also start to tabulate side effects. And then at stage 3, this is where efficacy in general is determined. And it's this point that women, that is female patients, are included in the trials, where they're starting to figure out exactly how effective is this drug and what are the adverse reactions. So in this way, women are not specifically studied for dosage or general efficacy. One perhaps troubling consequence of this is that if we have a drug that's effective only in male bodies, but not in female bodies, that drug will make it to stage 3, right? But if we have a drug that is, say, safe for women but not for men, or effective for women but not for men, well, it's going to fail stage 1 and stage 2, and these drugs will never become available to people who might benefit from them. But we'll notice that in this way, the exclusion of women from these first 2 stages is a way of having drugs that are less effective for women in general and drugs that are less safely dosed. So that's exactly this point. Many drugs with efficacy for only female patients just won't make it to stage 3. Here's one case study about how this kind of policy has played out. So we're doing research on dosing at phase 1 and phase 2. This is where women are not yet included in the studies. Now, there's a drug called Ambien. It's a rather famous drug because a lot of people use it. It's a drug that can cause a person to sleep, although it's not an opiate. So it's not supposed to be addictive. So if a person is having trouble sleeping and they need to get some sleep before they go to work, they say, well, 8 hours before my bedtime, I'm going to take an Ambien. I'll fall asleep within half an hour, get my sleep, and then be ready for work in the morning. But what happened is that they worked out a safe dosing strategy and then made the drug available to both men and women. But it turns out that a female body responds to Ambien in different ways than a male body does. I don't have the full explanation. It might be about different metabolic processes, and it might be a matter of different patterns in body fat to blood ratios for certain weights. But it just turns out that a woman who weighs 160 pounds will not metabolize Ambien as quickly or as easily as a man with the same weight. But what ended up happening is women would take Ambien, fall asleep, and then be woken up by their alarm clocks in the morning. But then, they would find themselves with this very powerful sleeping drug in their systems, could sometimes fall asleep while driving to work, run their cars into a telephone pole, that kind of thing. And many cases like this happened of women sometimes being exposed to certain risks and harms because this drug was not fully metabolized 8 hours later. So it took multiple incidents, and it took 20 years to recognize this pattern of over-prescribing a dosage of Ambien for women before they finally revised dosing guidelines saying, look, if you are a female patient rather than a male patient, you should be receiving a lower dose of this drug so your body will be able to metabolize it within 8 hours. The big explanation for why this happened is because women were excluded from the phases of the drug trial where safety and specifically dosage were worked out. So we can ask, how can we evaluate practices related to female patients and pharma research? One way that we could go is utilitarianism, right? The utilitarian will ask us to say, does the decision we're making lead to the greatest happiness for everybody affected in the long run? And if maximizing overall happiness is the goal, we might realize that by excluding women from research, we open them up to serious harms. And in that way, there is a moral mistake being made when we adopt this policy of excluding women from pharma research. It might have been adopted in order to avoid harm, and especially avoiding harm to potential future fetuses. But that avoidance of harm may have opened patients up to the harm of adverse drug reactions in the long run. We could also think about a Rawlsian theory of right and wrong or justice. We'd say like just rules are the ones that we would agree to from behind the veil of ignorance, i.e. we would pick the rules of how society is going to be structured before we know what position we're going to wind up in. And we might ask the question, if you knew there was a chance you were going to be in a society that tested drugs but did not test them in a way that was tailored to and safe for your body, we might say that would be a policy we would reject from behind the veil of ignorance. So in this way, we might say like a Rawlsian theory could also open us up to giving an objection to these exclusionary pharma policies. So that's one way in which we see sex-based discrimination and sex-based harms emerging within healthcare. Let's move on to a second topic, and this involves consent and medical training. One thing to notice is everybody wants to receive the best healthcare that they can. And in that way, people would typically want to avoid receiving medical care from somebody in training rather than somebody who has already been fully trained. But we might realize there's a problem here, right? If we all only ever accepted healthcare from a practitioner who was fully trained, we would eventually run out of skilled medical practitioners as the trained practitioners retire or die. Of course, every good medical practitioner at one point was in training. Now, in this context, we'll learn about one thing that a medical practitioner is trained to do. And this is something you would learn in medical school when you are in the obstetrics and gynecology phase of your medical school training. So when you're receiving your obstetrics and gynecology training, you will be taught how to perform a pelvic examination. Not everybody listening to this has undergone a pelvic examination. So let's just run through what the process is. This is where a gynecologist or a medical student would insert 2 gloved fingers into a patient's vagina. And at that point, they would use their other hand to palpate the patient's abdomen. And basically what they're trying to do is they're trying to catch the patient's uterus and ovaries between their 2 hands and to palpate them. They feel them in order to check for abnormalities and to understand the anatomical structure that is in a particular patient. So this is a process which is intimate. That is, it's involving a patient's genital regions. And it's also a process that's uncomfortable for patients. Now, one thing that happens in some medical schools is that there are teaching hospitals. This is a hospital where medical students are receiving their training in helping to care for patients. And when a patient goes to one of these hospitals for a gynecologic procedure under anesthesia, so perhaps this patient is about to receive a biopsy on an ovary, or perhaps the patient is going in for tubal ligation under anesthesia. It has been standard procedure at some of these teaching hospitals for the lead surgeon to perform a pelvic exam. This is part of what's going to happen before a patient begins their surgery. But then what happens is medical students will then follow up and redo the pelvic exam. So the doctor will find and feel the patient's uterus and ovaries with their hands, and then they will tell the medical student working with them that day to repeat the procedure so that they can learn how to perform a pelvic exam. Many medical students see this as an excellent teaching opportunity or an excellent learning opportunity, because when the patient is under anesthesia, there is less concern about that patient being uncomfortable or finding awkwardness between them and a patient learning to do this procedure for the first time. And there is general consent for being treated in a teaching hospital. So when a patient comes to a hospital that's connected to a medical school, they will sign a form that says, I consent to receiving care within the context of a teaching hospital, and I understand that that means that some aspects of my care and doctors and students working with me, some parts of that care will be educational. But one thing to note here is that when a patient goes in for gynecologic surgery and they're given a second purely education-centered pelvic exam, patients are often not given specific information about the fact that this second exam will happen, and there is no specific consent for that pelvic exam that's sought by the doctors or the medical students. So in this paper by Shawn Barnes, who is at this point a doctor, but who wrote this paper while he was a medical student, expressed concern about this practice. And he also notes that when he tells non-medical professionals about this practice, they are shocked and horrified to learn that a second pelvic exam is being given without specific consent. Now, the other thing to note is that pelvic exams under anesthesia without specific prior consent, they are now illegal in about 10 U.S. states. When Barnes wrote this paper in 2012, it was illegal in 3 states. And by the time it was published, it was also illegal in Barnes's current state. He was living in Hawaii while he was receiving his medical training. It's now illegal in about 10 states. Here where I am in North Carolina, unconsented educational pelvic exams are still legal. Now, there was a bill in the NC House in May 2021, but it died in committee. The last I've looked, a second attempt at the bill was made in 2023, but that bill was simply filed and has not received further votes. So it's looking like both attempts at making this practice illegal in my home state have both failed. We sometimes say that these are bills that die in committee. So one thing that we want to do is we want to be philosophical about this. And even though Barnes is a medical student writing this paper that we're talking about, Barnes does take a very philosophical approach. So what Barnes does is he says, look, there are concerns being raised by patients and medical students about these unconsented pelvic exams. But it seems like there are certain arguments that have been offered within the medical profession defending them. So what Barnes does is he looks at each of these arguments and then offers a response. And if there are no good defenses of the practice, and if there is a good reason to avoid the practice, that is why Barnes would favor laws that would require specific consent. So one line of defense just says, look, unconsented medical student pelvic examinations on women under anesthesia are standard practice. And when a patient comes into a hospital and signs their general intake form, they're consenting to receiving general practice. So in this way, specific consent would be a non-issue. But Barnes replies, so he says, like, the American College of Medical Students, the American Medical Association, as well as the American College of Obstetrics and Gynecology, they are all against this practice. So in this way, to say that the General Institution of Medicine is okay with this, Barnes says that's simply false. And he also examines the line of thought that says, look, when you sign that general intake form, saying that you will receive care at a teaching hospital, you give implicit consent for such an exam. But Barnes finds this problematic as well, saying that often a patient going to a teaching hospital doesn't have any other hospital to choose. So why they're signing a consent form is to receive care, not to volunteer their body as a subject for teaching. He also points out that some doctors will say, look, a medical student doesn't need to ask for specific consent for every minor activity that they may perform or help with during a surgery. So it's not as if a medical student has to go to a patient before a surgery and say, is it going to be okay with you if I cut some sutures? Is it okay if I help closing an incision or retracting some tissue? The thought would be, these are all just part of the work, and a patient will implicitly consent to all of these parts of standard care. And they will also say a practice pelvic exam is part of how a medical student will learn. We might also point out part of what you do as a medical student, and this is part of professionalism within medicine, you will see a patient's naked body or have to touch a patient's sexual organs, but you will not sexualize the patient in the process, right? So we might think that for a doctor and for a medical student, the right attitude would say that a patient's vagina is just another part of that patient's body. So just as it's not a big deal for a medical provider to have their finger in a patient's mouth, let's say, it's also not a sexual act for a medical professional to have two fingers in a patient's vagina. It's just another body part, right? Now, Barnes considers that line of thought, but says this is mistaken. He thinks that pelvic exams are fundamentally different. So having a finger in a patient's vagina is just a different thing than having a finger in a patient's mouth, given how intimate and personal a person's sexual organs are. We might think that even if doctors don't see a patient's sex organs as any different from any other part of their body or not a big deal, it's still true that the patients will see these parts of their body as importantly different from other parts of their body. So Barnes is going to say there is something fundamentally different about how we should receive consent when we're dealing with a patient's reproductive organs as opposed to some other part of their body. Barnes also points out that medicine already acknowledges that there is something fundamentally different about pelvic exams. Because as a male doctor, Barnes notes that he does not have to have a chaperone in the room when he, for instance, palpates a patient's abdomen or their thyroid gland, let's say. But if he's performing a pelvic exam on a patient who is awake, it is expected that there be another medical professional in the room with him. That's because there's a recognition that this has to be done with a certain kind of care, caution, and discretion, and accountability. So Barnes points out that we can't just say that touching a patient's, say, vagina is no different than touching any other part of their body. Fourth point. Some people will say there's no such thing as a practice pelvic examination in gynecologic surgery, so the point is moot. In fact, one of the first times I taught this paper, one of my students mentioned that she had worked as a nurse's assistant in the context of gynecologic surgery, and pointed out that there was an instance where the attending physician performed the pelvic exam and then told a student to perform that same pelvic exam, and the student noticed a problem that the attending physician did not notice. And in fact, they were able to give that patient the help that they needed because of the problem that the student noticed. I think that's a really interesting and powerful point, but Barnes is going to say, look, a student is legally not allowed to diagnose or carry out care alone. And the rationale, the reason why we do the exam a second time at all, even if it does lead to a good result or catching something the first doctor didn't catch, the aim behind performing the second pelvic exam is only and is inherently educational in its nature. So Barnes is going to say that the intention behind the second pelvic exam performed by the student is, in its intention, a practice exam. So he's going to disagree with this line of argument. Fifth line of argument says this: well, if we started asking patients about to receive gynecologic surgery, whether a second non-medically necessary pelvic exam would be performed, or asking the patient if they're okay with that specific pelvic exam, the concern is that no women would give that consent. And in that case, students would miss out on a valuable learning experience, which would jeopardize the competence of future physicians in performing a part of gynecologic care, which is absolutely necessary. Barnes replies here that two studies, one in the US and one in Canada, say that in one case 53% of women said that they would be okay with receiving a second education-only pelvic exam under anesthesia. The other study from Canada put the number at about 62%. So in this way, maybe there would be fewer pelvic exams if we specifically asked, but there still would be many learning opportunities for the students. So in this way, and this is captured in the title of Barnes's paper, why not ask first? Right? And that question of why not ask first says, look, we could receive the same kind of education, but without having to mislead or not inform our patients about what's being done to them. And this is why Barnes thinks that there's a problem with medical schools that allow these unconsented gynecologic exams. So Barnes's proposal is roughly that there should be laws or policies within med schools that require specific consent for pelvic exams. And he says by requiring those sorts of conversations to happen between female patients and medical students and also their attending physicians. This would teach students, as Barnes puts it, or Barnes quotes it from another source, the precedence of patients' rights. That we would have better gynecologic care if we taught our medical students that asking is an important thing to do. Now, one other thing that we'll flag is not everybody within the field of gynecology agrees with Barnes's concerns or his proposal. So in a later issue of the same medical journal, Obstetrics and Gynecology, two MDs wrote a response to Barnes's paper. They say this: the argument that students' input rarely is required for decision-making is a slippery slope. Medical training is an apprenticeship system, and trainees' evaluations rarely are required by attendings. Should trainees then obtain explicit consent for any role in care when the attendant has direct responsibility for the management? So it seems that one point that they're raising here is that part of how we train medical students to be doctors is for them to take this secondary role in working with patients. And they're going to say that the attending physician, not the medical student, has responsibility for the kinds of conversations that happen with the patient. They're going to say appropriate consent is essential for ethical practices, and attending physicians should decide how best to approach each patient. Legislation mandating how this is carried out and by whom may have serious repercussions for medical training. So we encourage incorporating guidelines into daily practice rather than enacting legislation that infringes on patient-physician relationships. So the Toche and Thiel argument in response to Barnes would say part of how we're going to train better doctors is to give judgment and leeway to the attending physician. And in this way, they're going to say that the sorts of laws that have been passed in about 10 states now, and which have not yet been passed but are being considered in my home state of North Carolina, we should avoid those and instead focus on working on institutional practices within specific teaching hospitals, which may vary in how they deal with different cases. So I'll leave that for you to reflect on. Should there be laws requiring explicit consent? Should teaching hospitals have their own self-made policies? Or should things be left pretty much the way they are? I think that that's an interesting question to reflect on. But what I've tried to do here is show that this is yet one more case where we can see certain impacts, not only in the well-being of women, which we saw in the discussion of exclusion from pharmacological research, but we also have disrespect of autonomous choice among female patients, apparently in the case of these unconscious pelvic exams. But there's plenty to reflect on here and plenty to think about how we can make our healthcare systems more inclusive along these dimensions of sex and gender. So I'll look forward to continuing the conversation. Thanks for listening in, and please reach out if there's anything you want to let me know about your perspectives on these cases. So thanks for listening, and take care.